And welcome to Scientific Sessions 2021. Bob Harrington from Stanford University. Really great to be here with everyone this morning. Our session is going to be on the potential impact of virtual studies. What we're really trying to get at here is to try to understand how some of the new technologies, the new ways of collecting data, monitoring data, analyzing data might be of value to cardiovascular research in the years ahead. We have a terrific panel of 5 leaders in the field who are all working in very, very different areas of virtual medicine, of digital medicine, of high technology medicine. And they're going to, the format will be is that each of them will spend about 5 to 7 minutes telling you what they do. And then from there, we will go ahead and have some questions for them. I'll start the questioning, but what we're really hopeful for is that you'll add some questions to Slido, to the chat, through social media. We have a great social media moderator, Dr. Erin Mikos from Johns Hopkins, and she will be monitoring her Twitter account to see who is going to ask questions. Feel free also to direct message me on Twitter at HeartBobH, and I'll see if I can't pull your question into the discussion. So with that as background, let me open it up with Dr. Callan McRae from Boston, who's going to kick us off. So Callan, I'll turn it over to you.
Well, thank you very much. I'm excited to be here today. I am a cardiologist, a geneticist at Harvard and Brigham and Women's. We also run a translational innovation program for the Department of Medicine. I have the fortune to be the director of One Brave Idea and the PI of the Apple Heart and Movement Study. And so we've been working quite extensively in this space over the last 4 to 5 years. And I thought probably the best thing I could do was to really just outline 3 overarching areas I thought might be useful to seed our conversation this morning. The first one I think is inclusivity. I think one of the things that's really exciting about longitudinal virtual studies that use wearables and other technologies and incorporate much more continuous or semi-continuous data flows is the opportunity to really change not just the study of disease, but also wellness. We have a chance, I think, to move completely outside the confines of the traditional medical environment, begin to empower and engage people across a much broader range of health states to understand that full range, not just define ourselves by the absence of disease, but really think about how we can positively manage and preserve wellness. This, I think, also helps us eliminate disparities and inequities by measuring them much more directly. And I think that's one of the lessons we've taken from some of the large studies we've done with Verily and Apple. The other elements of that inclusivity are the ability to change the scale and pace of what we do by reducing our dependence on recurrently obsolescent infrastructure. We have the opportunity to measure things in real time, to sample and resample in ways that overcome a lot of the issues that arise from specifically setting up infrastructure for a dedicated study. And importantly, those same approaches, I think, let us include the right metadata, much broader than just the core biomedical data, really incorporating environment, social determinants of health, existing care, and the background activities that I think in some instances are often minimized by the current structure. And then finally, I think the other element of inclusivity that's super important is the ability to understand mechanisms, understand diseases and health at an individual level. And that rigor, I think, really has the ability to transform the way that we understand the definitions of baselines and the identifications of the earliest deviations from health or specific endpoints in disease. At the other extreme, the second point I think I'd love to include as we think about this morning is uniqueness. I think rare disease studies of natural history and intervention, which we've done quite a few of, have taught us, I think, a couple of very important lessons. One, it's incredibly difficult to be precise without being comprehensive. And as part of that, we need to really reimagine how we collect data and how those data are used for the benefit of other individuals with similar biological trajectories. We need to reimagine the relationship between industry and academia and between industry and patients. There are often too few patients in these settings with the specific attributes you need for a given trial for us to really end up with separate entities involved in the management and the study of patients. And I do believe that even with rare patients, we've learned lessons that the distribution of subjects and geographically, as well as the data transparency that you can build into modern technologically driven data science, can begin to address a lot of the conflict of interest challenges. And then the final idea I think it's worth our while thinking about as we wind our way through the morning is convergence. All of those core ideas are beginning to move us in the direction of a convergence of biomedical investigation and clinical care or traditional preventative care, even if only because we can't afford to have separate systems at a global scale. And you're starting to see some of these implications emerge. I don't think anybody who has lived through the last 2 years would be surprised that we need to transform the way we collect data in our current systems. 500 million individuals infected, probably as many as 5 million or more who have passed away, but rigorous real-time data collection from fewer than 100,000 individuals impacting the decisions that we're making. And this is the driver, I think, for reimagining the way in which we think about data collection and what we actually collect in medicine. We're not going to be able to change the scale of the information content without broadening the scope of where and how we collect it. And then finally, in that regard, I think it really does, particularly when you start to look at how data flows, artificial intelligence can work together, we need to stop thinking about studies as episodes, but actually much more as continuous closed loop activities, which is what we need in any event for AI to truly be used optimally. We need to think about how we're continuously optimizing outcomes for society, for those who are well, those who are moving toward disease, and those who actually have disease. And I think those elements are going to be vital parts of the discussion over the next few years. And really bring together a lot of what we're talking about this morning in the potential impact of virtual studies. So I'll stop there and
Alan, there's a lot of things I could sort of draw you out on, but I want to maybe get you to comment. You talked about inclusivity, you talked about access, and certainly at these meetings there's a really important focus on bringing people into the medical system, into research, who have been historically left out. Is that what you're referring to? And how do we, one of the things we talk about is technology a help or a barrier to being more inclusive?
Well, I think that's a great question, Bob. I think as with all questions, the answer is always a bit of both. I think technology can certainly be a major hurdle to inclusivity, but I also believe that you can't manage what you can't measure. And so I think one of the things that we need to really think about is how, as we scale massively, the types of data we collect, the extremes of every axis actually begin to contribute to the information content. And I think what we've learned through our work with both Apple and Verily is that unless you're really thinking about those extremes of data in any axis, you're not really addressing the fundamental questions that you think you are. And so data-driven measurements of information content will help us, I believe, not necessarily automatically address those challenges, but recognize where access and inclusivity have been compromised and move directly based on data to address those disparities and inequities. And I think that itself, I think, is a valuable way forward.
And Callum, you don't have to answer this one now, but I want to tee you up to start thinking about it. Your final comment, which I really liked, was moving from episodes to continuous. And I want you to tell our audience, and maybe all of us on the screen here, how are we as clinicians going to deal with continuous data? It's already particularly my primary care doctors in my department tell me how hard it is just to keep up with their inbox with post-pandemic or in the pandemic. Tell us how we're going to keep up with continuous data. And you don't have to answer that one now, but we're going to come back to it. Next up is my longtime friend and former Duke colleague, Dr. Monica Shaw, who's going to give us a perspective from the research industry. And I'm looking forward to hearing your remarks, Monica. It's good to see you this morning.
Great. Thank you, Bob. And hello, everyone. As Bob said, I'm Monica Shah. I'm the head of the Cell and Gene Therapy Center of Excellence at IQVIA. And for those of you who aren't familiar with IQVIA, we're a contract research organization. And so we actually run the clinical trials that yield all these great results and important changes for our field. I'm going to share some slides here. Go ahead and pull these up. What I'm going to be talking about today is decentralized trials, because I really think that these have been a game changer for our field and have really changed sort of the paradigm of clinical research by bringing trials to patients rather than asking patients to come to sites and adding more burden to their daily activities. I think, one of the things that decentralized trials is really, well suited for is because through bringing trials to patients, we're able to, really optimize recruitment, optimize retention, especially by being able to go to patients where it may be more difficult for them to access hospitals or sites. We're able to diversify populations as well. So really important features of decentralized trials. I think another key thing is that when we think about decentralized trials, oftentimes we're thinking, okay, so these are the right studies for chronic diseases, for phase 3 studies, for stable populations. But one of the things that, especially over these last 2 years, that we've really seen is that there's a wide variety of indications and even types of studies that you can use decentralized trials for. Phase 1 studies, you can actually, incorporate decentralized elements, data collection in some of the follow-up. For the long-term follow-up of some of our studies, like gene therapy studies, we're, really using decentralized trials to be able to streamline data collection. So it's really, I think, changing the way we're thinking about these trials has really been catalyzed, I think, over the last 2 years. And of course, COVID-19 has had a lot to do with it. In fact, I can tell you 2 years ago, before the pandemic, I was always a champion for decentralized trials, but I wasn't always getting the traction, from sponsors, even within my organization. There was just, a little bit of skepticism about how is this going to work and will physicians accept it? Will patients accept it? Well, what we learned with COVID-19 was that this was really a platform that kept the momentum going, and that actually patients liked it, physicians liked it, and it was really, a way to keep research going in a time where, there was limited access to hospitals. I think while the idea of decentralized trials is really exciting, I think it's very important to note that it's fully underpinned by a lot of different technology, by different things like e-consent, electronic capture of outcome endpoints, connected devices. It's important to have the technology that not only allows you to collect the data, but is also patient-friendly and is able to be usable by patients. And I think really importantly, you have to have the right teams. You have to have people who know how to, kind of execute these types of studies. You have to have home nurses, phlebotomists. You have to have trained investigators who feel comfortable with this. And I think with the age of telemedicine now, we're all very comfortable with it. But, this is a really critical part, is having the right investigators in place. And then, of course, having relationships with the primary care providers who, patients are interacting with as well. And I think that's really critical as well. So I think there's a lot of moving parts under the umbrella, if you will, of decentralized trials. And all of these things, I think, have to be in place to ensure patient safety and to ensure that the results are really as robust as possible. So we've been using decentralized trial in the time of COVID-19. And I think what I wanted to do is maybe share some really exciting, I think, results from decentralized trials. I think they have, as I said, really kept the momentum going and have really allowed us to accelerate clinical research in a time when it was absolutely critical. So here's an example of how we use decentralized trials during a COVID-19 vaccine trial. Here, the sponsor needed to increase their geographic reach. Timelines were absolutely essential. And using a decentralized trial platform, Our organization was able to recruit more than 40,000 patients in less than 120 days. Another critical part of this study was patients completing patient diaries. And so adherence was very important. And with the scalable patient-reported outcomes tool that we had, we were able to collect that data. And you can see here, the amount of data that was able to be collected. And I think the point here is that you're able to go to patients, be able to recruit, and be able to really retain those patients and get the data. I wanted to just finish up with just a different aspect of decentralized trials, and that's direct-to-patient recruitment, actually going to patients with technology platforms, using media channels to be able to recruit them or tell them about studies directly. And I think, again, this is a way to be able to broaden patient populations, to be able to diversify populations, and to reach people who may not necessarily be hearing about clinical trials, even with their own healthcare providers. Here's an example of that. We were involved with an Operation Warp Speed trial sponsored by Big Pharma. And, the sponsor wanted to diversify their patient population. So we used direct-to-patient recruitment. And what that means is that we basically take a database that involves medical claims and prescription data. We're able to identify the right types of patients, match that up with some consumer data, with a consumer database, and understand what those patients are reading, what they're listening to, where they're most likely to be contacted. And so by really connecting those two databases and using AI and ML, we're able to target messaging around specific trials to patients, get them aware or increase awareness of studies, and then directly bring them to a website where they learn more about the studies. And if they're interested, they can directly go and learn more. And I think that's really different from the way we usually recruit for clinical trials, where you screen at a site, you spend a lot of time kind of going through the process of trying to find the right patients. Here, patients can directly come to you for further screening. So you can see the results here. We were really using this approach. We were able to rapidly recruit a large number of patients, and I think very importantly, increase the enrollment of a diverse population. With marked increases in our African American participants, Latinx participants, and importantly, elderly participants as well. And I think that's a concern that, oftentimes that elderly patients might not be able to use some of these devices or not be as familiar or comfortable. And I'm not sure that, from what I'm seeing, that I'm not sure that that's always the case. So I think it's great to see that a lot of our assumptions are challenged by using some of these new technologies. So I think with that, I think that my final thought here is that, while COVID-19 has really presented a lot of challenges and, has created a very challenging environment for all of us, it's also been a catalyst for change. And really, I think decentralized trials and really thinking about different ways of doing these studies has been one of the great things that has come through this.
Monica, first off, as a longtime clinical trialist, congratulations. This is really exciting news. And I'm particularly interested in this last slide around the diversity aspect. It's been one of the great challenges to have clinical trials that are as diverse as the population we hope to ultimately be treating. So I'm going to ask you a question, and you can decline to answer it if you like, but I'm hoping you'll answer it. We talk about faster and cheaper. You're talking about faster. You're talking about more inclusive. Are we going to be able to be cheaper?
Well, that's a great question. I mean, I think that, one of the things to recognize is there is a lot of technology, there is a lot of services that are involved in decentralized trials. So, in order to maintain patient safety and in order to, ensure good results, we have to have that infrastructure. So there's a certain amount of cost, I think, that regardless of how much we streamline, we're always going to have to make that investment. I think innovation also takes investment. But I also think that, as we get more, as this becomes part of everyday practice, as this becomes the way we do clinical trials, I think that models will evolve and this will become just the standard way we do things. And competition will bring prices and costs down. So I think, and yes, I do think that while things are new right now, that will, I do think that we'll be able to move to a more cost-effective model.
Yeah, my interest in this, as you might imagine, is if I think about it, there's a fixed pot of money, so to speak, to do investigation as a society. If we can spend less on a given unit, we can then maybe answer more of the questions that we all want to see answered. So I'm going to come back to some of this, Monica, get you thinking about it during the open session. But next, I have the privilege of introducing Dr. Shruti Malankaya, who is, I really want to thank her for joining us, because she's joining from outside what I would call the typical cardiovascular medicine realm, joining us from Boston. And maybe, Shruti, you can give the audience a little bit of your background, and then let's dive into your presentation.
Hi, Bob. Thank you so much. I've just lost screen control. I'm not sure you can hear me, but oh, here we go.
We can hear you. We can see your slides. If you can put them in presenter mode, we won't see the sidebar, but we can see your slides. There you go. Perfect.
Fantastic. Well, it's great to be here. I am an OBGYN by training. I'm a reproductive endocrinology and infertility specialist. And I am one of the co-PIs of the Apple Women's Health Study. And I'm super excited to be here today to talk about using digital tools to understand women's and menstrual health across the lifespan. So let's see. So firstly, if my slides cooperate, and I apologize, but the menstrual cycle is a very important part of health. And Bob, can you confirm that you only see my presenter mode?
We can see part of your slide, not the whole thing. Do the other panelists, do people see more than that? Okay. Give it another shot.
Technical difficulty.
Yeah. No, that's okay. It wouldn't be a technology session without having technology problems. It's always a good message that we're all still learning how to do this stuff.
Yes.
If you have trouble getting them up, the other way would just be you look at your slides and then just talk to the audience. And
there we go.
Yeah.
Yeah. Got it. Bob, I'm going to have you skip me. I cannot overcome my computer's screen lockout. So
no
come back
worry.
to me in just a minute.
Elizabeth, are you okay if we go to you?
Sure, thank you.
I'm going to jump to my friend and colleague, Dr. Elizabeth Opheli, who is going to give us her perspective from Morehouse. So thank you, Elizabeth, for joining us today.
Sure, thank you so much. Glad to be here. So I am a professor at Morehouse. I also am founder and chief science officer of AccuHealth Technologies, which has been working with Morehouse and other physicians that serve predominantly underserved patients to expand access to clinical trials. So I will discuss one of our most recent efforts through NIH NCAT's funding to expand access and remote monitoring for clinical trials using a Health 360X platform. So we actually start with understanding the context of care and chronic disease management, because that's a big part of the driver of health disparities. This is a TED Talk by one of our investigators, Dr. Paymo at Morehouse, who basically shared the challenge of health living with chronic illness and how the technology, essentially health coaching engagement, has allowed very difficult patients to come into compliance with care. So we start here because our proposal to the Small Business Innovation Research is really targeting how to get these patients who are in multiple practices across the country many of them not participating in research, how to actually get them engaged in research by working at the point of care. And what happens with Health 360X, again, which is the name of the platform, is it does have multiple interfaces. The patent really speaks to chronic disease management by connecting devices and bringing patients into that connectivity, but also engaging providers and bringing the data into a central repository to support research and other outcomes. So from this patient standpoint, it is an app that's available on Apple and Google Play, and they can self-monitor. They don't ever have to send their results to anyone. They can also send it to a health coach. The health coach, through their portal, can engage and help manage, and also a physician through the provider portal. What's happening with a number of individuals that are participating at essentially community practices is they're using this now for remote monitoring of these patients. And so through the NCATS NIH Small Business Innovation Fast Track Award that was provided to us back in March, we are now testing among these providers. And again, remember, these are providers that are not part of the current clinical trial ecosystem. They are not at academic health centers. Their infrastructure is quite limited. And so the platform really, this is this blue person everywhere, Health 360X, is able to work with an integrator to actually access data directly from the electronic medical record. Patients also, because they are on the platform, can share their data, and also thanks to additional new laws, patients have access to those EMR data as well. So we have two ways of getting connected with the EMR. The other thing at the level of the patient is connectivity to any devices that they're using, so we can pull that data, and we also are able to push data such as consent. We have specific interest in integrating social determinants, and we have worked closely using the FENEX toolkit at NIH that has many, many important questions that integrate social determinants. And importantly, patients can send in their own reported outcomes. As part of this onboarding, obviously systems are in the cloud, and we have also integrated active engagement because we send patients messages to allow them to know that they're connected with us. You see PHI everywhere and PII because we have learned, we started to work on this now since 2012, and we've learned that many African-American patients and Latinx are suspicious of some technology if they don't have certainty about how their privacy is assured. So we're very transparent about this, how we connect to devices and how we connect to software and infrastructure such as Redcap surveys through our academic health center collaboration, the CTMS, and central labs. So we are fortunate to actually essentially test this out. Shortly after we got our funding from NCATS, we're working with a major pharmaceutical company that wants to run a 10,000 patient cohort of a cardiovascular problem. And because we had previously established a cardiovascular implementation study, which is a repository that uses the platform to bring data in, we were able to identify there's about 10 or 12 practices that are Vanguard sites, 100,000 patients in the practices that are potentially eligible. These practices on their own are monitoring 1,000 of those patients currently, and more are being added. And it's just what they're doing from a chronic disease standpoint. At the same time, we know we want to identify 10,000 patients, and we're in the process of doing that. So in another year, by the next AHA, we should be able to give you some data. What we're looking at here is essentially a way where a patient's care goes on, they're able to be monitored, but also the practices are able to participate in research, even though they have limited infrastructure. And we think this approach is critical in promoting health equity, especially because we are working with known tools to aggregate and disaggregate data as we look at the various social determinants of health. And I thank you very much.
Elizabeth, fantastic, and congratulations for taking these steps. As I started my question to Monica, I said, as a longtime clinical investigator, let me now put on a different hat. As a longtime leader of a clinical research coordinating center,
Yeah.
what happens to the site and the investigator? Do we no longer need to train people to be lead investigators because we're going to go right to the patients? I mean, what's their responsibility, and what do you have to teach them?
So this is a very good question. In our model, we while we still go directly to patients, we importantly anchor within these smaller practices because, as you know, many of the National Academy of Medicine effort has said the fact that we're leaving out these community organizations, federally qualified centers, these are all part of our provider ecosystem, means that they're probably not likely to be as engaged in the discovery process. So we actually do train them. And what we found, for example, with the Vanguard sites is because they're already comfortable how the platform works in doing their day-to-day care with their patients, difficult patients, remote monitoring, then they're, it's not that they're eagerly embracing research, but they're cautiously looking at it and saying, okay, as long as we don't lose money. And the SBIR funding that we have is actually working with practices to develop SOPs so we don't obstruct the process of care, but we also bring in clinical trial as a potential, let's be frank, people don't want to lose money. They want to potentially gain resources. So it's now saying, hey, this patient that's in your practice, that could be a clinical part of a clinical study. How can we do that? If you don't have the coordinators, we can supply the coordinators to help you. If you do have the coordinators, we want to make sure you're participating fully so you can leverage the data for future outcome studies. So potentially it's a win-win, but obviously there's going to be a lot of questions that we need to make sure we're addressing upfront. Data privacy, who sees data, who owns data, how that data is shared. And we're just excited to be a part of this. Thank you.
No, again, congratulations. And maybe this will be a question that I'll have both you and Monica think about when we get to the open session. And that's this issue that you've alluded to a couple of times, Elizabeth, the better integration of research into practice, which has been like this, at least during my professional life, an elusive goal. And so maybe you and Monica can talk about that when we get to the open session. So thank you again. All right, Shruti has been texting me to tell me that she's back and ready. So let's go back over to you.
Thanks so much, Bob. I'll just jump in. I see your red dress pin. And so we will talk a little bit about how the menstrual cycle and heart health are connected. And then I'll talk a little bit about digital platforms. So to repeat, menstruation is important. It is a physiologic variable. It occurs frequently in a woman's life, typically monthly, every 28 days. And that range can be as short as 21 to as long as 35 and sometimes longer. And we're still kind of understanding normal. Menstruation is a whole body process. It requires the healthy functioning of the endocrine systems, as well as the organs of the uterus and ovaries, and hormones have an impact on the entire body. Menstruation is considered a vital sign. Irregularity can be a marker of disease, either transient or more concerning for a chronic issue. Furthermore, for this audience particularly, irregular menstruation alone or with androgen excess, either clinical or biochemical measurements, gives an increased risk for all sorts of cardiometabolic health parameters, including cardiovascular disease, hypertension, diabetes, obesity, and premature death. Looking in the pregnancy window, irregular menstruation can also be a marker of pregnancy-related complications, such as gestational hypertension and gestational diabetes. Yet, menstruation is under-researched. There are many reasons why this is the case, including lack of infrastructure and technology for prospective collection of bleeding days. And so I'm excited to share that with emerging technologies, we may be able to move forward, going from individual tracking to population level insights to facilitate risk identification and health optimization. And so one of what excites me as being part of the Apple Women's Health Study is that the data that we collect may be more representative of the population who menstruate. We can understand trends at the population level through individual level tracking. We can expand this window into health that the menstrual cycle may give and understand what confers risk, how severe must the irregularity be, how long must a person experience that, and what can we do to ameliorate that. And finally, understand multiple different factors enabled by sensor and other tracking technology to understand what can promote the cycle-related health and longitudinal health, including exercise, diet, sleep schedules, outdoor activities. And so I'll just briefly mention the platform of the Apple Women's Health Study. The aim is to really understand how demographic and lifestyle factors could impact menstrual cycles, as well as other gynecologic diseases such as infertility, menopause, polycystic ovary syndrome, and long-term health outcomes. We're recruiting a population that can be as young as 18, and there is no upper age limit. Participants must be within the United States at this time and have menstruated at least once. The tools that we have for longitudinal data collection include the iPhone, which facilitates delivery of survey-based questionnaires with different cadences, anywhere from monthly to quarterly to annually. We have cycle tracking, which can be within the Apple ecosystem and HealthKit or through a data sharing with any menstrual tracker. And then collection of other exposures and behaviors through sensor-based collection within the phone or the watch. And so I'm excited to hear your questions and bring in the perspective for women's health and cardiovascular health using digital platforms. Thank you so much.
Fantastic, thank you, and thanks for being flexible with moving around. This is an area that AHA has gotten very engaged in. In fact, Dr. Mikos has been one of our leaders in the field of trying to understand the intersection of things like pregnancy and long-time cardiovascular health. Erin, do you have any questions that you want to ask as a starting point? I have a list, but I figured you're the expert. I wanted to come to you first.
Okay, great. Thank you. Yes, I guess, first of all, I want to congratulate Dr. Malahagia about her Apple Women's Heart Study. I mean, it really was impressive. It recruited a large number, 10,000 participants, women, they're diverse in race and ethnicity, education, economic status, all using an Apple iPhone. But, retention is always an issue. And I guess I would like her to talk a little bit more about whether retention in the study differed by these diversity status, by race, ethnicity, and socioeconomic status. Because I think people can lose interest in interacting with tech devices over time. And so what are strategies to keep this diverse population engaged, these 10,000 women in her study?
Thank you so much, Erin. That is a great question, and it's something that we think about quite a bit. Retention is a key factor. I did share in the chat the first paper that kind of looks at the demographics among those who enrolled and then who stayed participating at 6 months within the first 10,000. We have recruited beyond that at this time, but one of the things that we started to do as a result of our findings of kind of attrition is doing something called a study update that facilitates participant engagement and interaction with the app and contributing survey-based data. So firstly, there's a few ways to categorize participation over time. And so survey-based data is one of those. A second feature is sensor-based data or tracking data. So if we are very strict with ourselves and define this through return of surveys, we have the lowest kind of participation rates noted. And if we define this as contribution of track data or sensor-based data, we have a much higher kind of participation rate. With that said, the study updates are a data visualization of a hot topic pertinent to our participants, and uses the data that they've contributed to show or give insights on menstrual health or trends. So we, of the 3 study updates that we've done, one was a general informational message about cycle tracking and its importance on health. The second study update was looking at the diversity of period symptoms contributed, and this was very insightful. We did some preliminary testing to understand, does this actually increase engagement with the app? And it seems to a little bit. And then the final update that we just rolled out was looking at attempts to conceive during the pandemic. And so we're trying to engage with participants using the data that they've shared to keep them interested and involved, and learn something from what they're sharing with us.
Terrific. Yeah, that's a comment, Erin, that I wanted to come back to, which is the whole issue of engagement with these tools. So thanks for asking the question. Thanks for the answer. And maybe it's a topic you can all be thinking about. Before I introduce our final speaker and panelist, Elizabeth, I have to ask you a question that just came across Slido. People want to know, are you walking while you're talking? Because, because here was the comment. It's from Leslie Davis, who I think is my colleague from North Carolina, who's a leader in the Nursing Council. She says that if she is able to walk and give such an engaging talk, that's a great message for heart health. So thank you, Elizabeth, for walking while you're giving your speech.
Thank you.
It probably tells all of us that we should not be sitting down all day, but stand up. So, so thank you very much. And thanks, Leslie, for raising the comment. All right. Last up is my friend and colleague from Vanderbilt, Dr. Dan Roden. Dan, I'm going to turn it over to you.
Thank you, Bob. I feel like the proverbial fifth wheel. I'm going to sort of emphasize some of the themes that you've already heard within the context of the All of Us initiative. So I have many, many titles, but these are the 2 that are relevant to what I do here. I've been interested in ways in which to deliver personalized or precision medicine for the last at least 15 years, arguably much more than that. And currently I serve as a co-principal investigator for the Data and Research Center for All of Us. And I want to tell you a little bit about All of Us and how it's going to take some of the themes that you have heard about and really scale them up in a very, very large population. So All of Us aims to recruit at least 1 million people and use their electronic records and use engagement with them through surveys, through digital health technologies to track their health longitudinally. This is a current snapshot of where we are. Over 400,000 participants have signed up. Not all of them have complete records of everything, so there are over 250,000 electronic health records. There are over 300,000 biosamples. And importantly, in a really, really important part of this has been a real focus on including people who are traditionally underrepresented in biomedical research, and that includes racial and ethnic minorities, it includes rural populations, it includes the elderly, as we've heard. And I will say that it's easy to say that, but it's very, very difficult to figure out how to do that. And All of Us had a run-up phase that lasted at least a year, more like a year and a half or 2, during which we had multiple engagements with underrepresented populations across the country in church basements and federally qualified health centers to understand what it would take for them to become excited about a program like this. So it takes a lot of work, but it is certainly doable. The Data and Research Center, of which I am a part, our partners are at Vanderbilt. I'm one of 2 co-PIs. I'll mention who the other one is in a moment. We also have partners at Verily Google and the Broad Institute. So our mission is to get the data in, to secure it, to organize it, and then to deliver it to the research community, very, very broadly read. And research community includes not just academic researchers, but international researchers, industrial researchers, high school students, college students, people not affiliated with academic centers, and we are working on mechanisms to do that. I will say that we're not there yet. One of the things that I think is most important about the way All of Us is organized is that we have developed a new way of delivering data securely to investigators. So this is the traditional approach. You bring data to the investigators. Investigator comes to a large database, extracts the data, downloads it to their own server, and does whatever it is they want to do. And the problems there are that revolve around security, or revolve around an infrastructure, and then revolve around what kind of tools people are using. What we have done here is that the investigators come to the resource in the cloud. So there is centralized security controls. I've learned all about the word exfiltration. It's accessible. We have accessibility protocols that allow access to researchers to the data set, not on a project by project basis, but on a passport basis. Once approved, you can do more or less whatever you like, using the tools that we've developed, tools like a cohort builder and like simple data analysis tools. And then the storage costs obviously are smaller because individual investigators don't have to worry about that. There is a data browser. I just stuck this slide in within the last couple of minutes. There's a data browser. The most important part of this slide is the link to the data browser that shows what is available. And I thought I would sort of highlight this by saying that there is a Fitbit data set, and the Fitbit data set is actually pretty interesting. There are over 30 billion cumulative steps monitored in the Fitbit data set. Currently, over 4,000 people with a median follow-up of 3 years. So people are using this data set, for example, to ask the question, are there specific health conditions that are associated with more steps or fewer steps? What happens to steps during the pandemic? Those kinds of interesting questions. And it's not my job here to reveal those answers. And I'll just say people are working on that. You've already heard about Redcap. Redcap is the brainchild of my co-principal investigator at Vanderbilt, Paul Harris, and Redcap has been a real interesting tool, not simply for e-consent, which is one of the things that you've heard about, but for capturing data in a variety of situations. And Paul and his team have developed new tools for capturing specific data streams. And I think that this is one of the themes that we're going to hear more and more about as we think about how to use newer digital health technologies to drive clinical trials. So, for example, there are Redcap apps for malaria detection, Redcap apps for sleep patterns in autism. There's a very nice app for diagnosing early Parkinson's disease, and Paul and his team developed a very nice app for following people with COVID and deciding at what point do they need to engage the health system and at what point can they stay home. So I think on that note, I will stop and just emphasize that that we're almost halfway into recruiting a very, very large cohort, which will be useful to answer whatever questions you have.
Fantastic. Number one, thanks for helping lead these efforts, Dan, which are critically important to the overall country's efforts to understanding things like health and wellness. Let me ask you a question, not so much dealing with a science question, but a governance question. If everybody's high school students, senior researchers, everybody is utilizing this democratic tool, how do you make sure that people are doing it appropriately, and that we're not seeing things appear, for example, in the literature, which are things that you might not think are valid? How do we do that?
That's a great question. I think there are two levels, and I'll be explicit about addressing what I think are at least two levels. One is people may make mistakes when they do their genomic analysis, but there are other very large assets around the world, notably the UK Biobank, and people are allowed to access UK Biobank data and analyze them to their heart's content. And and occasionally come up with answers that are incorrect because they do the incorrect analysis. We have to rely on a peer review system to do that. The thornier issue, which I think is what you're driving at, is what happens when people start to do research on, the genomic basis of whether you graduated from high school. And I think that's it will be inevitable that that people will start to do that as these resources become democratized. The UK Biobank has already had examples of that, where they have looked at, in a project, they do project by project approvals, although their projects are very large, but their project by project approval ran the difficulty of that they had a group of investigators who went outside the boundaries of their defined project and actually published a paper that generated a huge amount of feedback, of pushback, because it was, widely viewed as not only inappropriate but wrong. And I think we have to rely on the wider community to do some of that. We obviously, one of the things that the centralized system does allow us to do is to look at people's notebooks. This is all the research is done within the context of something called Jupyter Notebooks. So those are, anybody younger than me knows how to program in Python or R, and that's what we use. And all those are become public. So anything you develop, any algorithms that you develop, any data sets that you develop are available to other people. So we're able to look retrospectively at what people have done, but I think it's a big issue, and I think it's wider than the community. It's not a very satisfactory answer, but I think
no. I think it's a good answer, because we could have a whole discussion on whether peer review is adequate, or as Churchill said about democracy, it strikes me that it's the worst form of review except for all the others.
Yep.
And the notion of what should be peer review, I've been highly influenced by Harlan Krumholz, who is really pushing the preprint notion and the crowdsourcing of review. And maybe that for things of this magnitude that are supported by all of us in through our tax dollars are something that we should consider. So I'm going to come back to you on this, Dan, because I think there's some interesting things to talk about. But first, I'm going to go, first off, thank you for all of you giving such terrific presentations. We now have roughly 35, 40 minutes for questions, which is perfect, what we wanted. And Erin, I'm looking at my Twitter account, and you are bombarding the airwaves with social media updates on this panel. So are you getting any questions that you want to pull into the conversation here?
Oh, well, there's been a lot of comments, and I apologize. When you called on me earlier, I was busy tweeting. So if I looked a little flustered when you called on me, I was jumping back into the Zoom conversation from tweet. But there's been a lot of positive feedback. I just wanted to read a couple comments, and one came with a question that goes in Slido. Nancy Brown, our CEO of the American Heart Association, had comment about Dr. Shaw's presentation and had said that decentralized trials are really critical. Without them, we lack the opportunity to improve population health. And then about Dr. McCrae's presentation, Nancy Brown also said that she really appreciated his thoughts on inclusivity and technology, and that he's spot on, and that we can't manage what we can't measure. These studies can change that. So I really like that. We can't manage what we can't measure. But for Dr. McCrae, there was a Slido question. So you mentioned digital tools can both help and hurt diversity in trials, and that rare diseases can benefit from these tools. So how can we bring digital tools to other populations, children, adult, congenital, pregnant women, et cetera? How can we incentivize industry to pay attention to these patients?
But so I think, first of all, thanks, Erin, for the question. I think it's an excellent point that ultimately one of the first things we need to do, as I said earlier, is to measure the places that we're not going, understand the representativeness of the data sets that we're looking at, work out where the gaps are, the missingness is, and move into those areas deliberately. There are a whole host of statistical considerations in how you do that, but they're all helped dramatically by scale. But you asked a much more precise question, which is how do we incentivize folks. And I think actually it came up even in the last interchange between Bob and Dan. I think a lot of this is having really crowdsourced external review. When people understand that their conclusions are simply erroneous because they haven't actually involved the groups that they're really trying to research in a diverse and representative way, it begins to incent everybody to really think carefully about what they're doing. In practical terms, how do you do it? I think the reality is you build studies that ask questions that help you understand why it is that those individuals are not participating. Shruti mentioned beautifully, I think, the fact that this is an enormous study compared with all of the prior studies of menstruation, the Apple Women's Apple Health Study. But there's an entire suite of those particular approaches that we could use where we're actually actively targeting individuals. And that's where the rare disease analogy comes in. You can actually identify individuals often from data that we're not measuring in the medical system, but are measured outside the medical system, and go directly to those individuals. So there are lots of great examples of that happening. Even probably one of the best comes from the Undiagnosed Diseases Program, where a simple tweet recruited within 48 hours the only 5 other people in the world with a genetic condition, just by describing the symptoms precisely enough that the parents of these children immediately recognized the problem and contributed their child's DNA to the problem, to the research that allowed the gene to be identified very effectively and the mechanism to be described within weeks rather than typically the decades that it might take. So I think there are strategies that we can use by beginning to break down some of those barriers between traditional biomedical data, what we consider as identifiers, and the things that actually allow us to be inclusive.
Terrific. Thank you, Callum. Your comment about the tweet reminded me of something we saw during the Apple Heart study when we were enrolling patients in a subject rather in a sort of rather continuous way. And then Apple pushed out to all of their watch owners notification of the study. And it wasn't like a slight uptick in enrollment. It was like to the moon. And almost 500,000 subjects were enrolled incredibly quickly because of that. So yeah, the power of being able to do that is extraordinary. Dan, looks like you want to get into the conversation.
I just wanted to sort of add to what Callum said that I think that when you have very, very large data sets and things like electronic records and other patient information, you can start to identify patients who have undiagnosed diseases, undiagnosed Mendelian diseases lurking among us. We think that something around 3% of the population, so certainly somebody looking at this session, has at least, if not medical conditions that are driven exclusively by variants in a single gene, they have diseases that are strongly modulated by susceptibility alleles. So we can find them, and I think that engaging patients through surveys, through social media, and looking in detail using clever newer approaches at the electronic records and other sources of patient information is another way of finding people who are different from average and need to be treated differently from average.
Yeah, Dan, you're reminding me of many conversations I have with my colleague here at Stanford, Josh Knowles, in the quest to find individuals with FH. And it's an example of what you're talking about, because it's a group of individuals who are notoriously undertreated for something that's treatable.
And you'd think you could find those people just by measuring cholesterol, but even that doesn't work really well.
No, it doesn't. As I said the same thing when Josh first told me this. I said, well, how hard is this? Don't you just measure cholesterol? And I've been humbled to realize it's a lot harder than that. But you're all bringing up a question. Let me take one of the Slido questions here that I think is really good. It hits to what you're saying, Dan. Monica, you've touched on this. Elizabeth, you've touched on this. So I'd like you all to give an answer to it. Here's the question. Collecting real-time data presents a double-edged sword. What is our responsibility as researchers to step in if we see clinically worsening symptoms? So I guess, Dan, it's you identify something in a research way. What's our responsibility? Shruti, you're collecting this real-time data. You find that there's somebody who's suffering from something. When do we intervene? Maybe I'll start with you, Dan, and then we'll go around.
This is a really vexing issue in precision or personalized medicine. As you know, Bob, and many others may know, I've been involved with the development and creation of a biobank here that relies on de-identified patient information. And our agreement with patients is that they can contribute their data, but they will never get anything back from us. And so that there is this issue of, what happens if you find a highly penetrant BRCA1 pathogenic variant in one of those patients? How do you justify not returning that? And I don't want to go down that ethical rabbit hole, but there's a complicated set of thought that goes on around that. The UK Biobank is exactly the same thing. They have an absolute commitment to return absolutely nothing to their patients. All of us is the opposite. We don't have patients, we don't have subjects, we have participants. And those people are participating in the study, and the commitment is to return anything and everything that we can to them. Now, how to do that in real time as you see somebody deteriorating, that's a different question. But I think the commitment starts that way. And so we're doing a whole genome sequence, and we're going to return genomic data to patients. We hope to be able to start to return that within a year. We have about 80,000 whole genomes that we're going to return sometime, that we're going to make public this winter. So that's the sort of beginning of a next phase of this adventure. But I think you have to have an infrastructure where participants really are engaged as full partners in the research, and that's the way forward. And then develop the tools and the technology to actually deliver that kind of information to them.
Well, and now I got to poke at you a little bit here, Dan. There's a difference between maybe providing people data and providing people information. When you provide them the genome, I'd consider myself a fairly knowledgeable person. If you provided me my genome, I'd have no idea what to do with it.
Yeah,
are you going to provide me some usefulness?
Yeah, no, there is one of the many subcontracts around all of us. All the data research center is a subcontract, biobank is a subcontract, each of the recruiting centers is a subcontract, and there is a subcontract to provide genetic counseling broadly through color genomics. So we're not going to hand people a couple of terabytes of A's, T's, C's, and G's and say, have at it. We're going to provide them with, annotations, pathogenic variants, likely pathogenic variants, pharmacogenetic variants, ancestry information, that kind of thing, in a genetic counselor kind of context.
Great, thank you. I figured you were doing that, but I wanted to ask.
Good. Thank you for allowing me to clarify.
Shruti, you're talking about collecting real-time continuous data in some ways in the Women's Apple Heart study, our health study. What are you doing? What's your responsibility to provide people real-time information if they're giving you real-time data?
Thanks so much for the question. Right now, our study is set up as a observational study, so it's not a clinical trial, nor do we have trial of kind of risk assessment and kind of participant outreach for counseling. But what Dr. Roden is doing is amazing. I do think that as we collect large cohorts and refined temporal data, it invariably invites the question, well, you're going to have data to be able to risk predict, either diagnose or intervene, and what is going to happen then. This gets at what Callum said a little bit on the convergence of systems. And I think that we will have to be thinking about this as the data sets grow and our ability to interpret, aggregate, and make accurate predictions increases. So thanks for that question.
Yeah, and Elizabeth, I'm going to come to you. Shruti put an interesting question for you in the chat around the elements of trust. And I want to ask you, because you're particularly dealing with communities that historically, rightfully have lost trust in the research system. Can you talk a little bit about what you're doing to, first off, to answer Shruti's question?
Sure.
What are the elements of trust we should be thinking about as researchers in this arena? And what are you specifically doing in your studies to not just maintain, but really to to rebuild trust that's been rightfully lost?
Yeah, thank you so much for the question. So I think one of the key things that obviously we all see with COVID is there are trusted partners in the community. There are people that patients or participants trust. And sometimes these are their providers, sometimes they're their relatives. So what we do is actually build on what we've learned for decades of research at Morehouse, that when you go to a church community, when you go to a school community, when you go to providers who see predominantly underserved patients, you're basically essentially borrowing or acknowledging that they have trust. And so the onus is on us to be fully transparent. And a lot of what we do in that regard, regardless of the kind of study, is to make sure our informed consent has buy-in by the community of interest. So members of the community who form a community advisory board actually review the informed consent, and some of them choose to participate and they become messengers of the study. I really think some of the earlier discussion about returning results is also important. What we find with our patients is they really want to know. It's not about, the doctor filtering it down. So whatever you discover, are you going to tell me? Let me make my decision. So I think that transparency, letting them know where we don't know stuff, like, okay, we're trying to find out, we don't know the answer, but whatever we learn, we will share with you. I think at the end of the day, where research and care meet will become important, again, to that question. Because when you think about it, I'm doing some genetic study, I'm doing lipids, it doesn't matter how rare or common. That patient at the other end is thinking, well, what are they finding out about me? If I don't know, they lose interest. In fact, we find that returning results is a key part of our engagement. So we talk to the patients, okay, but you have high blood pressure, it's common, but it might manifest differently in you because of everything going on around you. So here's what we're finding. Your doctor is a part of the loop, but you can also talk to other doctors that are taking care of you. Patients like that because they become, they have agency in this aspect. I hope that helps. I didn't want to.
No. I think you're getting to a key theme. And Shruti, thank you for adding some more dimensions to the question. I think she asked a great question, Elizabeth, which is how do you scale community trust with these large scale digital platforms? That's a great question. Dan's dealing with 400,000 individuals and all of us. How do you get community trust on that kind of scale?
I think just like you do on a 1 doctor, 2 doctor scale, right? Because what happens is these guys, they talk to each other. So if you have a practice and some people are participating and you share the information, like you said, you did Apple study, a lot of people joined right away. But even for those who don't join, hearing about the experiences of their colleagues help them get understanding. Again, I think a lot of it is about the information, how that information is transmitted, how we acknowledge the relevance of that information to that individual. So whether it's a family history, a personal history, or the risks that they believe they have. I think that's all part of the package.
Thank you. Monica, you look like you want to jump in here. Go ahead.
Yeah, no, I wanted to just add to Elizabeth's point of, we're talking about technology and obviously it's the next wave. Decentralized trials, I think, are the next wave of how we're going to be doing clinical trials. But in all of this, you can't replace the physician. And I think that's, or the provider. And I think that that's really critical. All of our technology facilitates this, but obtaining consent, having that investigator who's overseeing the trial and, the site, even if they're virtually interacting with a patient, making sure there's connections with the healthcare providers, all of that is critical. And just because we're doing decentralized trials or novel ways of collecting data, that doesn't take out that really absolutely critical element of that human interaction. And I think that's a key, I think, to gaining trust, is making sure that a human being is always part of the process and somebody who really understands the science and understands the clinical issues as well as the technology and the implementation.
Thank you for saying that, Monica. It was a question I wanted to get back to for you and your trials, where you do talk about with the decentralized nature, there is a temptation to bypass the clinician. But in fact, the clinician-patient interface is critical. It helps, as Elizabeth and Trudy both said, it helps with trust. It helps with compliance or engagement, maybe is a better way to phrase that. So I'm glad you brought that up.
Absolutely.
Callum, do you want to jump in on the trust question?
Yeah, I would add, I thought Elizabeth framed it really beautifully. I think, and Monica's addition is super important. I would just say two things. One, I think it's really a central feature is to give people information they can use and then test it themselves. I think that's incredibly valuable. That closed loop at the wrist or closed loop on the phone or closed loop in the home is a critical part of what you need to be able to deliver. As Dan said, and you pushed him on, it's giving actionable information to folks is really powerful and not patronizing, but actually allowing everybody to get the information and then make decisions themselves about how to use it. I think that's how you build communities of engagement. That's how you scale them. And ultimately, I think that's the way I see the whole future evolving. I think it is actually, as I said earlier, it's amazing that we take information from so few people and then extrapolate it to the rest of the planet. We need everybody to be working on this because these are super hard problems. Not everybody has to be forced to participate, but if you're willing to engage and are able to contribute, no matter who you are in that pipeline of humanness and caring, you should be enabled to participate.
Well, you're bringing up a really important point, Callum. There was an interesting paper that came out earlier this year from Stanford, from Russ Altman's group, that showed that in the algorithms that are basically being built to understand health, so artificial intelligence, machine learning, et cetera, the data sets are coming largely from three places: California, Massachusetts, and New York. And in fact, there are 13 or 14 states, something like that. I'm trying to remember. No representation. I was recently Zooming into a meeting at the University of Mississippi, and they were appalled to learn that there were no Mississippi subjects included in those algorithm data sets. Comments, Callum?
So I'm reminded of two things. One, how far behind the rest of the world medicine really is. I think there was a great article in The Economist a couple of weeks ago where the entire science of economics has changed because instead of building interval experiments, people are now interpreting real-time data. And what it's done is displace a lot of the folks who were really the middlemen in this type of exercise. And I think you're going to see that happen in medicine. This is partly what's going to drive the convergence of care and discovery. I don't think there's enough information content, even in those three great states of Massachusetts, California, and New York, to really be able to answer the questions we need to answer in the timescale that society demands. And so I totally, in fact, one of the things I was when Dan was talking, I wonder if we're seeing the inflection point, particularly with COVID, where you start to realize that our current concept, even of what a trial really is, what a cohort really is, has to be completely broken down and rebuilt from scratch. We need to really be thinking, how do we build comprehensiveness into everything that we do? And I certainly don't want to suggest that we eliminate the need for peer review or intellectual assessment of what's happening, but I think we need to democratize that at the same sort of scale as we're democratizing the data collection.
So you're getting to a topic I wanted to get Monica's thoughts on. And I think at least two of you have used this phrase or something akin to it, which is the blurring of the lines between research and clinical practice. And as you might imagine, I'm very much in favor of that blurring. And because I think that clinical practice should just be the platform on which research is done. And I would like to see it be all inclusive. Monica, from the perspective of somebody who's thinking a lot about clinical trials, how are you thinking about that blurring and trying to make clinical trials more representative of what we do every day?
Thanks, Bob, for that question. I think that what you're referring to is clinical trials or clinical research as a care option, right? So really integrating it fully into what we do every day. And, I think part of the challenge is that it's difficult to do clinical research in clinical environments because, first of all, I think, teams are, sometimes we're not talking the same language. The clinical research teams are, thinking one thing, the clinician is obviously busy trying to take care of the patients. And so there's there's a divide there. And also I think, it's not easy. So we have to really focus anytime we want to make something happen. I think you need to make it easy. I think you need to see the other person's perspective. And so I think that's where these tools come into place. Let's make the data collection easy. Let's make the consent process easier. Let's streamline those protocols and really try to understand, is this necessary, or can we, potentially not collect that piece of data there? So I think to really be able to integrate clinical care and clinical research, we have to make it as easy as possible to do that through our tools and our technology. And I think we also have to kind of really begin to fully understand the perspectives of other voices. In the research world, we need to really be thinking about what's going on in a hospital and how patients are being seen, and making sure that these protocols make sense. And on the clinical side, really understanding sort of the importance of a particular study and why we need to make time to be able to do that. So I think there's a lot of things from those two perspectives.
Great, thank you. Erin, anything coming in from the Twitter universe?
Yeah, so a lot of great comments and feedback. People are enjoying the session. Some comments, of course, that crowdsourcing really provides an opportunity to obtain diverse data and improve accessibility and results. But there was a question in the Slido and about, as we're beginning to explore and encourage more use of digital technology and trials, maybe this is a question for Dr. Shaw, but how can potential barriers, specifically low digital literacy, be navigated? And are we excluding people in this population, and what additional support can be built into study protocols to cater this population? I guess the question is, we're talking about how this is opportunity to improve diversity, but does tech really improve equity or access, or does it actually restrict access because of problems with digital literacy?
Great question. I think I'm going to try to get everyone in on this question, Erin. So go ahead, Monica. Why don't you start?
Sure. So I'm a champion of. I think that we're always surprised by who's digitally literate, and I think we make a lot of assumptions. So elderly, patients. I've seen a huge uptake in like, for example, heart failure or cardiovascular communities with some of these digital technologies. I think one of the features that we have in our decentralized trials is what we call a study concierge, or a decentralized trial concierge, where there's 24/7 support to be able to call if something is not understandable, or if you can't use something. So again, I kind of come back to that. You can't just drop the technology in a vacuum. You have to have some human element or some sort of support to be able to make sure that people can use the devices and are able to access help. But I'm always pleasantly surprised by how much people can do.
Thanks, Monica. Shruti, what's been the experience in your studies with digital literacy and engaging a broad swath of the community?
Thanks for that question. So the design component of the app and the surveys, which was built to kind of limit the time commitment for each survey, hopefully provides an experience that requires minimal digital literacy. I think there are a couple of steps that are required to download the app and then undergo an onboarding process. And that's something that I'm, interested in understanding. Does it create a barrier, or does it actually enable inclusivity? And so it's something that I'm thinking actively about. Ideally, we improve inclusivity and reduce barriers, but as Callum mentioned, digital platforms can do both. They can either restrict or be inclusive depending on how they're rolled out. We do try to use language that is accessible in the survey questionnaire design, and the sensor-based data transfer is designed to be not time intensive after initial informed consent for sharing those data elements. So I am curious, to see how our study and our data with this platform may compare to other studies using kind of certain platform agnostic tools, like in the future for menstrual cycle, people who are menstruators who are in different geographic parts of the world or use different platforms altogether for tracking and health tracking.
Anyone else want to comment on digital literacy and what we can maybe do to overcome that? Elizabeth, you look like you just came off of mute. Go ahead.
That's right. Thank you so much. So we find in our studies that it is real. The digital divide is real. And I think that while there's excitement on some of what we're seeing with COVID, I think on the other side, there's real divide in terms of who will embrace some of these studies. This divide is much greater when you're dealing with chronic illnesses. What we find is it is important, whatever technology you're using, that you engage that community of interest in some kind of a focus group before you actually dive into the study, because you will learn a lot about what their concerns are. For example, even though Morehouse School of Medicine was a partner in bringing our platform to the community, it made a difference where we were going. In the church community, the members of the church were the advocates, the health coaches, and the navigators. And they had significant uptick in the technology versus in the workplace, like the city of Atlanta, where people had no trust about their supervisors getting knowledge about their health. So it's actually interlinked, but I also think it's real in terms of digital literacy, what people understand is going on within the platform, how they think their data will be used. It's all wrapped into whether or not you have uptake. And there is significant disparities right now that we really need to continue to address upfront. And I think it should be a part of every technology that's rolled out. What are you doing to address digital literacy? Importantly, where's the uptake, and what did you do to address that? Because we learn a lot in that regard. I do agree with Monica that some of the people we think won't embrace it, like the older individuals, sometimes I'm the first to be in line because they've got challenges that they want to deal with. I still think, though, we need to continue to look out for it.
If I could maybe just add to Elizabeth's point, I think your point about getting input on the design of the technology is so important.
Yeah.
And I don't think we do that enough. I think that that's such a critical part. It's just like protocol design, right? It's just getting the input right up front so that it's as user-friendly as possible.
Yeah.
Callum?
I was just 2 quick points. I was going to say the unit of inclusivity does not necessarily need to be the individual. Exactly as Elizabeth said, you can actually use technology to build family level or community level groups that are actually working around this. I don't want to minimize in any way the challenges in doing this, but technology can really be used effectively in that way. And then the one other thing is there are also lots of passive technologies that are becoming available that really have multiple uses, not just in healthcare, but in lots of other parts of our lives and could be multi-purpose. And there are many entities that are thinking about how those can be used in the home or in other settings where the level of literacy you might need to participate is less.
Give us an example, Callum.
So one of the best examples that comes to mind is there's now a fairly tight correlation between ultra-sensitive sensors for water use in communities as a means of detecting leaks in homes, reducing the cost of home insurance. Those tools are readily available to actually look at overall activity for an individual. So you can actually track whether somebody is actually behaving normally based on their use of water. So it's actually a very quick way of in a multi-dimensional, almost chatter fashion, understanding whether somebody's health and wellness is stable. So,
yeah, there's a whole literature that's emerging on ambient sensing devices in hospitals. For example, we outfitted our new hospital and half the ICU beds with visual technology that can track movement. And turns out that, for example, in an ICU, a ICU nurse makes about 600 to 700 unique movements during a shift. Then you ask yourself, well, which movements matter? And can we go ahead and inform people that, like, look, you haven't made these movements today. You haven't turned the patient. You haven't gotten the patient to sit up. You haven't checked that IV bag. And those are interesting questions, but it also raises a whole other set of questions about intrusion, privacy, et cetera, that we could certainly go on about. We got about 5 minutes left, and I want to ask a question that I think is provocative. I'll see what the group here thinks. With everything that you're talking about, you've all mentioned the notion of consent, informed consent. Is the way we get consent outdated? Do we need to get consent when we actually don't know what to do? Should we be randomizing like our engineer friends do, A/B testing all the time? I mean, this gets to this integration of practice and research. Anybody want to jump in on that? Dan, you want to jump in on that?
Not really, but I will. I think it makes most of us a little nervous to start to say, well, you don't need consent. I will say that when we started our biobank, because we de-identified the information, we were designated non-human subjects, and we had an opt-out mechanism as opposed to an opt-in mechanism. Those are nuances that in 5 minutes we don't want to dwell on. We have had examples here where I worry that because of a focus on consent, we're losing an opportunity to actually understand how we practice. So, when I'm not doing this, I hang out with the electrophysiology service because I'm an arrhythmia doctor. And our guys are very interested in knowing, whether this particular approach to atrial fibrillation ablation is better than that particular approach. Now, you can do a randomized trial, but at the end of the day, I don't think it's really possible to sort of inform people, as long as there's equipoise, about whether ablating at this space or that place is better or worse. And so I think that we create consent mechanisms for detailed things like that, which ordinary people and actually ordinary physicians, just don't have the database to understand. So I think there may be wiggle room around what constitutes consent, but at the end of the day, I think that people need to know what's being done to their data, and you run a real risk of sliding down a slippery slope if you say, we don't need to ask people what we're doing. I mean, we have the Henrietta Lacks example. I think, for example, there are many, many other examples of times when people legitimately or not thought that consent was not necessary, and it turns out that you need to think that through. Just say it that way.
Yeah, no, it's a good comment. It's something that I think about a lot, which is that your EP example is a great one, which is those doctors can go into the EP lab and
they do an ablation,
willy-nilly decide which approach they're going to take without consent as to the specifics of it. And yet, if we want to actually learn from that by imposing the structure of randomization, then we take it to a whole different level. And maybe there are some questions. I know, Aaron, that the group at Hopkins from the Hastings Center is thinking a lot about this. Ruth McFadden had a great paper in the New England Journal a few years ago on the topic of why do we let doctors do what they do? And yet we make researchers go through this gauntlet of informed consent. Anybody want to take that?
So I can comment.
Yeah,
I do
good.
think that, as has been discussed, the informed consent has a role, but I think we also need to look at the importance and the value of pragmatic trials. Because on the other hand, we're now discussing real-time work, real-world data. Sometimes, especially in communities that I work with, they're not part of the clinical trial, and yet we're prescribing these drugs or devices for them. No one knows how effective those services are, but we keep doing them. So this is where a pragmatic trial that's not necessarily randomized, but still has rigor and requires some informed consent. And what we do find, and again, I think as you saw from the all of us and in the Monica's presentation as well, there's an opportunity for some front door opt-in or opt-out models where we can at least access patients and give them the opportunity then to tell us, are they willing to participate or not? I think where we are, where you absolutely cannot even approach a patient, that's where we're running into problems, because the patient themselves, sometimes they want to do this. And I actually applaud these new approaches that are saying patients can control their records, patients can decide what they do and where they go with their information, because I think that's going to push us more to go to the patients to make some of these requests. And so I think we're still evolving, and I agree that we don't want to get to the point where we're saying, do away with informed consent, even when you think you're mostly dealing with a clinical care situation with a pragmatic study.
Great comments. I want to, at the end of our hour and a half here, who would have thought that we didn't have a moment to spare? But thank you to the 5 of you for participating on the panel. Thank you, Erin, for being our social media moderator and keeping us knowledgeable about what was going on in the Twitter universe. Thanks to AHA for hosting this meeting. And I wish all of you in the audience an enjoyable sessions for the rest of the weekend. Thanks for joining us. Bye-bye.
Good job,
Thank you.
Bob.
Thank you. Great session. Thank you.
Bye.
Bye-bye.